Okay, so we have the final here, one of the final online tests. This one here, or online lectures. For some of the references, insulin management and therapy, Diabetes Association, Sick Kids, and I've also gone to the monographs for the insulin specifically. So this means monographs. I've actually gone to the insulin company, or the companies, the pharmaceutical companies that make these insulins, and then actually compared their onset duration and characteristics for each. Quickly introducing endogenous insulin. I'm not telling you anything here that you probably don't know from anatomy and now from pathology. Remember that insulin is a hormone created by the beta cells, very important in maintaining neuronal development, feeding behavior, basically the growth of your cells. And what we usually see is spillage of glucose into the urine that usually occurs between 9 to 11. So this is why we always want to keep, for a diabetic, we always want to keep their insulin levels in the normal range, and there can be some slight variation up to 10 when they spike. But in particular, we'd like to keep everything below 9 and 10. And as we know as well, when we talk about glucagon is one of the works in concert with, and this is a review from pathology as well. You've already seen this. And just another review as well. If you didn't like the previous diagram, here's another diagram to remember by as well. And as I mentioned in class the other day, just in case you're looking at stuff on the internet and you see that, oh my God, what the hell does this mean that somebody's blood sugar is 115? What the hell does that mean? That's not normal. That's because it's probably American. Okay, so here we see American versus, so milligrams per deciliter, and this is just a chart that just goes from left to right, showing you all the numbers all the way up to the highest level. We see that a normal blood sugar of 6.4, which we've talked about in Canada. Okay, so insulin looking at type 1, and as we said in pathology, similar to sometimes milligrams per deciliter insulin states, which is for so the Americans for sure, type 2 when they progress to everybody else as usual. Types of insulin. Basically, what we have to do is it's a regular form of insulin. It's highly soluble. It's mixed in. Excuse me. It's mixed with a buffer, and it's mixed with a zinc crystal. And if you want to, primarily what they figured out is if you want to increase or look at how long insulin, or delay how long insulin will onset, meaning how long it will take to start to be active within the body, you can play around with the amount of zinc that is in the mixture. You increase the amount of zinc, you increase the duration of action, or you can also play around with you can also delay its onset. So they play around with a thing called zinc or protamine. Okay, either one of these two, and you don't need to know specifically which ones, but which one is going to do which, because those are basically trade secrets, pharmaceutical stuff. But what you do need to know is that all you're doing is you're playing around with the buffer, or playing around with the mixture that the stuff is mixed in, and you can play around, and you can actually change how long it onsets, or how long the mechanism of action goes on for. And with that, we end up getting then 3 types of insulin. We get a short-acting, an intermediate, and long-acting insulins. These are just the general categories when people talk about insulins. Now, back in the day, okay, back in the 1800s, when insulin was made here up the street on College Avenue by Banting and Best, they basically only had one type of insulin, and we still have that for some uses today. We call it regular. The very first insulin that was ever made was called Toronto, and pretty much right now it was made from animal products, but right now we have recombinant versions of this that are made from that are still made, and there's 2 major insulin companies. So one is called Humulin R, and one is called Novolin R. This depends on what company you're getting it from, and the R stands for regular. And you'll look, and the differences in all these insulins, the most important part about the insulins, one of the biggest important parts, is onset, peak, and duration, because this is going to drive how you're going to do assessments on when you should assess blood sugars and when you should assess whether or not the medication has done what it's supposed to do. Onset 30 to 60 minutes for regular. Peak is when 2 to 4 hours. Duration is 6 to 8 hours, and it is something that is rarely, that you will probably rarely use unless you're still working with a patient over at Sunnybrook who is, left over from the 1800s, who hasn't been moved over to any other insulin, or just prefers to still use regular insulin. But what we will see is that it's primarily used in insulin infusions. And you're saying, hey, why would you want an insulin that takes 2 to 4 hours to peak and onsets within 60 minutes? Because when we're doing insulin infusions, we're doing it for DKA. And what we really want in DKA is we want a nice, slow, controlled drop of blood sugar, because anything too drastic might actually harm the patient, as we mentioned in pathology. So we use regular insulin for infusions because we see a nice, slower onset, so we can watch and do. And when you think of it, if you're doing somebody in the, if you have somebody in the ICU, and obviously you guys aren't going to need to worry about ICU patients, but this is the rationale. If we're looking at a patient who is on, who are giving insulin to on an infusion, okay, through their IV, we want to do a nice slow change of their insulin. We don't want something that onsets within 10 to 15 minutes, because that means you're going to have to be doing their blood sugar every couple of minutes to make sure it doesn't drop too low. This one here, we can do blood sugars in 15 minutes, in a half an hour, in 1 hour, and see whether or not the blood sugar is dropping. Because when you give an insulin infusion, you're also giving a glucose infusion at the same time, and you have to sort of titrate between the two to make sure you have the nice slow reduction in blood sugar, so that the body can heal from the damage of the blood ketones. So this is why we like short-acting insulins, because it is nice and controllable and fits in with doing blood sugars every 15 minutes, every half an hour, and seeing a nice slow, controlled drop of blood sugar. As I said, in DKA, primarily for insulin infusions. What you will see are patients who are not in DKA and who are not in the ICU, and patients you will see is they will be on rapid-acting insulins. And as I said, look at how quickly these rapid-actings work. They onset within 30 at Lispro Humalog, which is one of the older ones, 30 to 45 minutes. Then we have Nova Rapid and this other one called Abtibra, which onset within 15 minutes. Okay, these are super freaking fast. And quite honestly, and last time I was at diabetes camp, I hardly saw any kids who new diabetics on Humalog anymore. It was all Nova Rapid and Abtibra. Okay, why? Because you start getting changes very quickly, okay, which is nice. We see that the peak for these rapid actings, this one's 45 to 1.5 hours. This one is more or less the same as well, and we see a peak within an hour as well. So that means when we see a peak, that means we are seeing the most blood sugar that is going to be removed by that. And these are really important that we've made this advance to move to what we call Nova Rapid and Abtibra, because guess what we only use these for? Insulin pumps. Okay, I'm going to talk about insulin pumps a little bit later, but insulin pumps are what we prefer to use these for. Okay, and it's because they onset very quickly. And there's some administration notes. You can give 0 to 15 minutes before eating for any of the rapids, which is why we like it. You can go closer. You don't have to you don't have to take this medication an hour or two before. Okay, because of its peak. We try and match the thing in diabetes is we try and match the peak in blood sugar from eating when we're giving a bolus of insulin to the peak of the insulin, because if that happens at the same time, then your blood sugar will stay the same. If your blood sugar peaks before your insulin peaks in your body, then what ends up happening is if you take a patient's blood sugar after eating, it's going to show that, oh my God, they're hyperglycemic, they're 13, 14, 15, 16. Well, that doesn't mean that you didn't give enough insulin. It means that the blood sugar, the absorption of blood sugar occurred more rapidly than the onset and peak of the insulin. So this is why we try and match these. So this is why you can take the insulin a little bit before. We'll keep the blood sugar even after eating. Should keep the blood sugar relatively normal because you're seeing the peak of the insulin peaking at the same time as the maximum absorption through your gut of the sugar. So that's why we have that. That's why you give insulin prior to. That's why you give sometimes insulin, 15, 20 minutes sometimes, depending on the insulin. If you're using this Lispro, sometimes in 40 minutes before the patient eats. Okay, this is what most of them look like when we're talking about rapids. The interesting thing about rapid insulins is they are all clear now, okay? And so Apidra, which is rapid, Humalog, which we saw in the previous one, is clear as well. Humulin R, the regular, is also clear. Novolog, which is Aspart, that is clear as well. We will see that there is, and they come in these forms right here, where they can come in big vials, and they can come in insulin pens as well, these little cartridges. And I think I might have something for you guys a little bit later this afternoon. I'm going to play around today with some of the junk I have from left over from my daughter's stuff, and try and show you how certain things work. Immediate and long-acting insulins. So intermediate basically means there is going to be a delay. And I'm going to show you a slide in a little bit that has some diagrams on it of peaks of insulin to show you this, and I'll discuss a little bit more in detail about how this peak is a little bit different. But when we look at an intermediate, this is basically delayed, and these are cloudy. This is the only cloudy insulin around nowadays, okay? When I was going to school, there was only cloudy and clear, but now there are these long-actings down here, which have been made within the past 10 years, 10 to 15 years, which are very, very, very cool, and I'll explain why they're very cool in a little bit. Intermediate acting onset is in 1 to 3 hours, so it's delayed. It does nothing for 1 to 3 hours. At around 3 to 3 hour mark, it starts to onset and work. It then peaks from and all these times are from the moment you give it. So 1 to 3 hours after it is injected, it will start to onset, what means it will start to work. There is a delayed action that happens from this medication. And then 5 to 8 hours after the insulin is given, it will start to peak. And it lasts sometimes for, that peak will sort of stay there for about relatively around the same amount for about another 2 hours, or sometimes 3, not 2 hours, 3 hours, and then it will start to dribble away. And some patients, depending on what you're doing, whether or not you're sleeping or awake, it can extend up to sometimes 12 hours, and sometimes, okay? And it's the only cloudy one, and it's routinely, it's the only drug, this is the only drug that can be mixed in the same injection tube as rapid insulins. You can mix this with a rapid, and we have pre-mixed solutions of rapid and long-acting insulins that can be given in a pen form. And I'll show you what that looks like in a little bit. Now, the one thing about this one is still set to have a peak. It's meant, if we think of NPH, it has a peak and a plateau, okay, and then it drops off. It doesn't have the same sort of profile as regular insulins or rapid insulins. As well, long-acting insulins as well, we say this one doesn't even have any peak. It just sort of gradually goes up and keeps a steady flat line for a long period of time and then drops off. And we say that this one has no peak. It just sort of onsets and it's up to where it should be, and then it never goes into a big spike. It just sort of continues on. And these are very important. This is Levemir and this is Lantus. And like I said, in all my tests, I will give you both names on the test. I will give you both of these names in brackets, the common name and the trade name as well, whatever one you remember. Levemir only lasts for it lasts minimum 12 hours, sometimes may go up to 24, but pretty much we see it drop off around 12, in most uses as I've seen it. Lantus for sure lasts 24 hours, okay? So these become very, very cool to use because everything on this page here, okay, may be used for something, and I said about it in the bonus lecture on Wednesday and Thursday, can be used for what we call a background or to maintain the basal rate of what is needed of insulin, or the basal amount that is needed to keep the cells from going into DKA. Both of these can be used for this background or this basal amount of insulin that always has to be in the body. On this page, these are the ones that will be used for that. Okay. Nowadays, we see long-acting insulins used a lot. They are the better ones to use. As I mentioned in class, the main reason that we still have this intermediate junk around is for two reasons. And I'll get to it in a little bit. But for two reasons. One, it's dirt cheap. Two, it can be helpful if you want to skip injections, and I'll explain in the next couple of slides. So this is what the long-acting or intermediates look like, and you will see very closely that it kind of doesn't show up well. The reason it doesn't show up here is Humulin R, or what we call NPH, not particularly helpful. It is, and I'll get to why. It's actually white and cloudy, so this is why it mixes in with the background here. Well, you'll see if you look at Lantus and Levemir, they're actually clear, so this is why you see a little meniscus here. The reason why this is all white in here is because that's actually the medication. You see the glass up here you can actually see the glass in this picture. It is actually a white milky color. Lantus and Levemir are clear like rapids, where you can make a big mistake here. Okay, I've said in class, and I'll say it once here, and I'll say it again in a couple more slides, the only thing that goes into an insulin pump is rapid-acting insulin, the stuff that onsets within 10 to 15 minutes. That is the only stuff that should be going in an insulin pump. You stick this in an insulin pump, you are in freaking trouble. Okay, because now, as we are going to have an insulin that is going to last for 12 to 24 hours, depending on which one you use here. You will have an insulin that is now going to continue on for 24 hours. You don't want that in an insulin pump. And I'll explain a little bit better when we get to those slides when we talk about pumps. Okay, so what we're going to talk about right here is we're going to talk about the different types of insulin we have here. So when you look at all these insulins together, as we said, we've got these rapid acting, which has a very distinct peak up here. We have short acting, which has a little bit longer, a little bit wider peak, but it's pretty much still a peak. We have intermediate, which sort of has a peak, but then it has this sort of plateau for a little bit before it drops away. And the long actings, the Levemir and the Lantus, really don't have this defined peak in what they do. They sort of get up there and then just dribble along for either 12 hours or dribble along for 24 hours. You know, Lantus down here conceivably keeps going and then drops off at 24. We say that they're just both have plateaus. And in endocrine and diabetes education and anybody who is a diabetic, we use the following term. We say that Levemir and Lantus have no peak. The reason we say this is the characteristics of these three medications is they have peaks, and we can get a big, incredible, rapid spike in the mechanism of the insulin very quickly, or within a reasonable amount of time. To coincide with what? To coincide with a spike in blood sugar in your bloodstream. When do big spikes occur? outside of being sick, outside of being ill or anything like this, or being stressed, when do big spikes of blood sugar occur in a patient? When they're eating, shortly after they eat. So we would say that the rapid, the short-acting, and the intermediate can be used to match spikes in blood sugar. So you want a nice, big, rapid peak, because your blood sugar, similarly, is going to do the same thing. It's going to shoot up and peak in the background as well. Okay, so this is where in diabetes management we want to match. We want to match the spike in blood sugar with a spike in insulin after eating. So this is why we say we use insulins that have defined peaks in them. Okay, so we would try and eat. We give this, maybe an hour before, because within 20 to 30 minutes your blood sugar is going to go shooting up and spiking up here like this. If we were to map blood sugar on against these as well, we would see that we would want this peak in insulin to match the peak in blood sugar. Why? So that we see that the blood sugar levels stay normal. If blood sugar peaks before the onset and the peak of the insulin, what we would see is a period of time right after eating where the patient's blood sugar is quite high. Okay? And we see this is why we like these rapid actings. They peak within about 15 minutes. The short acting takes a little bit longer. Intermediate does have a peak, and it shoots out a peak over here, sometimes at the 4-hour mark. And the reason we would do that, just think about what I said. We use insulins that have peaks to match when we're about to eat. The NPH, and I joked about it in class, and it's not particularly helpful, and I'll explain why in a little bit, but the thing that it does, and the thing why it's still useful, is it's still dirt cheap to produce. And if you don't have insurance, it's dirt cheap for you to use. And the reason we're doing is, what if I don't want to, you think of somebody who's injecting themselves. They have to inject every meal. What if I want to skip an injection? What if I'm out and say, I'm going to go out shopping this afternoon, I want to sit down and lunch. I really don't want to inject myself in the middle of the mall, because it's embarrassing, or I just don't want to have to bother doing that. Or you're a child under the age of 10, and you don't know how to use an insulin pump because you're not familiar with that. Say you're 5 years old. Okay, my daughter was 5 years old when she was as a diabetic, and when she went to school, and she didn't know how to use an insulin pump, and her teachers don't touch insulin pumps. So what would you do in a regimented day, where you know how much you're going to eat at lunch, or how much you're going to eat at your next meal? You can give yourself this intermediate insulin, okay, at the same time you gave your insulin for a meal. For example, let's say breakfast. At breakfast, I eat so much insulin, so I eat so much food, so I need exactly the corresponding amount of insulin for that food that I just ate. Now, in preparation for lunchtime, I take also a dose of intermediate, and it will delay its onset and its spike for 4 hours. Within about 4 hours, all of a sudden it shoots up. Okay, it's almost like it stays dormant, stays dormant, stays dormant, stays dormant. At around the 3 or 4 hour mark, boom, it peaks up. Okay, so breakfast to lunch, 4 hours, this is when I would eat, and I don't have to inject myself if I'm using intermediate. Sounds kind of good, but there's only a little problem here. You have to make sure you eat exactly 4 hours later. You can't wait until, oh, maybe I'll eat over here, because what would be happening if you waited and ate 2 hours after lunch? You would be going hypoglycemic, because the intermediate becomes active. So it is useful. It is still used in school-age children who are unable to figure out how to use the pump or responsibly use a pump yet. And it is used in those situations, and it's dirt cheap too, so it might be used in people who don't have the money to spend, or the insurance to spend, on the expensive long-acting insulins. And it's not only the long-actings, but also to use you can only afford the rapids. Okay, so rapids are expensive. Long-acting and Levemir and Lantus are expensive. Intermediate is dirt cheap. So if you're on a budget, then what you're going to do is you're going to spend all your money for your rapid, and then you're going to use intermediate. And you're going to use intermediate for two things. in a large dose, you can use it to skip an injection at a lunchtime, okay? And or for children, when we know they're in school-age children, when we know they're in school and they are going to regimentedly eat at noon, you can also give this so that teachers don't have to do injections, or the child does not have to do an injection at school. The only thing they have to do is they have to eat, and they have to eat exactly the right amount of carbs. Okay? That's it for a kid who's at school age, who's not on a pump. So that's why intermediate still has its use. And if you're an adult and you don't have the money to spend on long-acting insulins, which are expensive, then notice in smaller doses, then this will go towards the assignment that I gave you. Look very closely there. You will see some little humps overlooking each other. Little humps of 2 to 4 hours, okay, that last up to about 4 to 6 hours. We're talking about using intermediate insulin. Intermediate insulin in lower doses, because it kind of gets stretched out in its action a little bit to like the 8 to 10 hour mark. Okay, we can also use it as a background or a medication that can be used, or an insulin that can be used for the basal metabolic rate that is running in the background of a patient that needs to be always there. Intermediate can be used this way. It's not the greatest way to use it. In most situations, I would say the best way to use it is to use it to skip a meal later on if you're an injector. But it can be used for those patients who have been stabilized on it for this regime, but it means more injections, it means more insulin. So intermediate could be used as a background insulin in smaller doses. It can be used in large doses to skip a meal. And guess what? This is why we call it intermediate. It sort of plays in between rapids and long-actings. It can sort of be used as a delayed rapid-acting insulin for a meal later on. It can be in smaller doses over small doses, multiple doses over the course of the day. It can also be used to mimic a long-acting insulin, which works in the background for that to satisfy that basal rate of insulin that always needs to be there. Now, if we throw money out the window and we throw everything, basically what we would want is a patient who is taking a long-acting that works to take care of that basal rate that always needs to be there. And I said this in class, that the basal rate is the minimum amount of insulin you always need in your body to prevent your blood sugar, to prevent your cells from going into DKA. Ideally, we would want you to be on a Levemir or Lantus to cover that over the course of the day. Okay? And then you would only then need to take as an injector rapids when you have a meal. So this is for somebody who does injections, not a pump. If you're doing injections, you will use ideally a long-acting medication or long-acting insulin to cover the background insulin, and then over and above that, when you eat, you need to take care of the sugar that will spike. So a really good pattern is what we will see is a long-acting insulin, okay, an expensive long-acting insulin in the background, either once or twice a day, depending on which one you're using. Once a day for Lantus because it's 24 hours, twice a day for Levemir because it works for 12 hours, and then every time you eat, you take rapid. Okay, that would be the ideal way for an injector to use their insulins. But unfortunately, money, and for other reasons as well, we still have this intermediate working in here. And as I said, the intermediate can be used depending on the pattern that you use it. You can use it to skip a meal. My little ones are awake right now. You're probably going to hear them in the background insulin. Now, here's a slide that you do not have. Okay, I threw this in at the last minute, which is why I delayed putting out this lecture, because I realized that there was a topic that I did not explain as well, and I want to make sure that I do. So if we look at two insulins here, given at two different times, we have a short-acting insulin, which has a discerned peak, and we have this NPH, which we gave an hour or so later. Okay? Let's just look at the short acting here for a second. Okay? 2 lines that I have drawn here. Okay? We have the minimum effective concentration for these 2 insulins. Okay, and this is conceptual, please. This is not exact numbers for these 2 things. All right. Notice I haven't said which NPH this is or which short acting this. This is just conceptual right now. All right, talking about the categories of drugs. I give you a short acting. It reaches the red line, the minimum effective concentration line, and it starts lowering blood sugar. What did we say it happens in minimum effective concentration? The amount you need to see your effect. So this is where your onset, and this is, we have 1 to 5 hours right here, 0 to 5 hours, 1 hour mark approximately in here. This is when we would say that we actually started to see, let's say if this is a short acting, we start to see, sorry, not in an hour, we say within this short acting insulin that it starts to onset within about half an hour, 15 minutes to a half an hour is when we start to see an onset of action. Well, there we go. Here is the green line, which is telling us the time is about a half an hour to 15 minutes to a half an hour. We see that it reaches the minimum effective concentration. Everything on this side of this peak, or this side of this hump going on, we see dropping blood sugar, dropping blood sugar, dropping blood sugar, dropping blood sugar. We see the most amount of blood sugar drop here, and you can even say that it's rapidly losing blood sugar, rapidly, and then as we get over the peak, then we start to see, yes, blood sugar is still dropping, maybe not as fast, it's still dropping, and then we see that once we get below the minimum effective concentration line out here for this short acting, we see that it is done. Okay? All right, we see that there is no further drop in blood sugar from this short-acting insulin. Okay, I know all the times are all different here. Okay, relax. This is conceptual. When we have an insulin that is short-acting, okay, it will take an amount of time before it starts to onset and drop your blood sugar. Over the minimum effective concentration line, we see a rapid drop in blood sugar and then a slower drop in blood sugar for the period of time that you are still above the minimum effective concentration for that short-acting insulin. After that period of time, even though there still be some left, you have no effect. We call the insulin that the period of time between here and here, specifically on this downslide here, at this point right here, we still have insulin working. At this point right here, we still have insulin working. At this point right here, we still have insulin working. At this point down here on this curve, the insulin is ineffective. It is not working. So everything above this, in this part right here, this downslide right here, we call this from the peak to here, in diabetic lingo, we call this active insulin or insulin on board. Okay, and this is a term that gets used in diabetes a lot. The reason being is because when I talked about it in class, and I'm going to talk about it and sort of leading up to this slide right now that's going to happen later on, when we talk about stacking blood sugar. Okay, we are very concerned about, after the peak, whether or not we still have insulin on board. Okay, how long will this insulin still stay above the minimum effective concentration line? That's important, because if you give another dose, you will run into the risk of stacking your insulin if you are still within this time range of here where we say insulin is still active, or you still have insulin on board that is effective. Okay, and so this is a term that I wanted to make you guys aware of as we go forward into the lecture. I'm starting it with you now because it's very close with the previous slide. If we look, I've put the NPH here as well, just to sort of give you a contrast of why NPH can be used as a background insulin sometimes. We would see that for a background insulin, this minimum effective concentration line would actually shift downwards, okay? And we would see that that there is, when we're giving NPH, that we're giving lower doses of this, and this is where it can be used as a background because it lasts for a long period of time. Okay, it does have a peak, which if we give a good hefty dose of it, we could use it to skip a meal later on, or we could use it as a background insulin because of this long period of time that it lasts over here. But we would have to give, if we were using this as a background insulin, we would have to give another dose of it within about another 4 to 6 hours here, and we would see a duplicate sort of this hump, this hump and or this peak and plateau. We would see it over here. So I've told you two things. The main thing here is the insulin on board part, and if we look at the insulin on board compared to the short acting as it compares to the NPH over here, look how much longer we have with this NPH and how much longer it could give us an insulin on board for. Okay, it stretches that time out. So this is what we're always talking about. How long do we still have active insulin on board for? Okay, those are the two terms I wanted to make you aware of. Active insulin, otherwise known as insulin on board. Okay. Couple of things that we can do when we're talking about injectors is we can mix rapid and NPH together. Intermediate insulin can be mixed with rapid insulin, or it can be mixed with regular, but primarily since we only use rapid, we tend to use rapid only these days for injections. That's why I'm saying rapid and NPH can be mixed together. Typically, as I said, as I've already mentioned, what it can do is it can reduce the number of the injections per day by giving you a big dose of NPH. We can skip a meal later on. This provides continuity in blood sugar levels in the absence of insulin production, blah, 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 blah. Of course it does. The only thing that you need to do when you're giving insulin NPH as for the purposes of skipping a meal, you have to make sure that you plan ahead of time so that the timing of when it peaks matches the time of when you are eating, and there has to be a specific amount of food and there has to be a specific time. The specific amount of food must match the dose of NPH that you've given yourself. And there are also, and as I mentioned, you can also use NPH as a background insulin as well. Premixed forms of insulin are available also that are to treat stable diabetes. So you can either manually mix up rapid and NPH in the same insulin tube, or it can become pre-mixed in set portions, and we'll talk about that as we go through here as well. These are called prepared mixes of rapid and NPH, pre-mixed doses that combine rapid and short actings, and the name of the preparation basically indicates the proportion of each type, okay, such as we have 30-70, 50-50, and this is more convenient and reduces error, reduces the person who's mixing up the error of me mixing up, did I actually mix up how much I was supposed to? Okay, so pre-mixed insulins are generally not recommended for children. The reason being is because we have to mix up very small doses, and I will show you later on in a video what I mean about that. So the premixes are not used for children because we need more flexibility in the portions, and they're much smaller portions. But we usually see these being used in diabetics who are older adult diabetics, and the 30-70 and the 50-50, we will show you what that means in a little bit in the next slide. This is what it means. The first number, when we see, this is what it will look like. Humalog mix 20. So this is, we will see 25, we will see 30, we will see 50, we will see 30-70, 30-70, or 40-60, or whatever. Whatever it means, the first number you see is always the rapid, and that means the remainder is the NPH. So if we look at Humalog 25, that means, well, they're only giving you one number. So that would be the first number. They're, in this one here, in this company here, they are assuming that you have a brain, and they are assuming that if I say Humalog mix 25, they're assuming that you would say, hey, well, 25 is rapid acting, and I can do math. I can go 100 minus 25 is 75. That means that 75% of that is intermediate. This other company doesn't assume that you can do simple math. Okay, they're assuming you're a little bit more stupid, and they actually write 30-70 or 40-60 or 50-50. Okay, and in that one, the first number again is the short acting. Gee, I wonder if I would ask a question about that. Damn right, because you better know what the hell you're picking up when you're giving it to your patients in Sunnybrook or in long-term care. Now, if you have to mix these, if you don't use a pre-mixed and you have to draw it up for a child and have to mix up your rapid acting and your cloudy insulin, you always draw up the clear before the cloudy. Okay, now there's been, in the past several years, there's been a back and forth going on saying in pediatrics, no, we should drop the cloudy before the clear, and blah, 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 blah. This Sick Kids is now on board with this, and all pediatric centers are on board with this now. Okay, the reasons why they kept flopping back and forth is not important, but what is important is that whether or not you're talking an adult, whether or not you're talking pediatrics, it is the same right now. The rationale of why you drop the clear before the cloudy is to avoid contamination of your rapid insulin with your cloudy. Okay, in the pre-mixed insulins, they are already set, okay, and they've made a little chemical jig in there so that they do not interact with each other. But the reason is that you don't want to be, it's not that the NPH will screw up the rapid acting and change the properties of the rapid acting. But what if I were to continually put in, accidentally put a drop or put in a unit of insulin, of NPH, the intermediate, into my rapid acting? What does that do? Well, it dilutes it out, and it's going to be acting, it's going to be introducing an insulin into that rapid acting that's going to onset when? 4 hours later. What happens if and if you continually do that every day and you're continually contaminating your rapid acting vial, what's going to happen? I'm going to go, hey, I want to give myself some rapid because I am eating right now, and I go and inject myself. What am I injecting myself with? If it's contaminated, I'm injecting myself with an unknown portion of NPH that is going to onset later. And what it's going to happen is I'm going to inject myself, and some of that's going to onset later. I think I'm injecting myself with exactly the right amount of insulin for my meal, for my blood sugar that's going to spike in an hour. Okay, and then 2 hours later I go, hey, my blood sugar's still high. I better give myself some more rapid to bring my blood sugar down. I wonder what screwed up, huh? Well, what you're doing in both of those situations is, unfortunately, you're giving the reason why your rapid didn't work the way it was supposed to is because there is some intermediate mixed in there. So it's like giving yourself a premix when you don't want a premix. Okay, so that's why we want to avoid cereal, or not breakfast cereal. Cereal means one after another, repeating. We don't want to continually to contaminate or dilute the action of what our rapid insulin will be doing with cloudy. Okay, because it could mean that later on we could have a big hypoglycemic event. All right, so that's why we do that. And we always have an independent double check for insulin. It is a insulin that requires an independent double check. It is on the list of high-risk medications that medical errors can occur. And the question we do with this is the checker must both see the clear and cloudy drawn up, and they must see the final amount that is in, and just seeing the final amount that's in the syringe, like I just pull up a syringe and go, hey, I mixed up cloudy and clear in this, look at it. There's 10 units in it. That's not sufficient. What is sufficient is that the other nurse sees you draw up the cloudy and sees you draw in then the and sees you draw up the rapid as well in the same syringe together. That is a proper independent double check. Just walking up to your colleague and saying, hey, look, I drew up 10 units of insulin, 3 of it is NPH, is not sufficient. How do I know, as the double checker, how do I know that you actually put in 3 units of NPH? I didn't see it. You don't see it, it didn't happen. Okay? That is important as an independent double checker. Some things about insulin care. Unopened insulin can be stored in the fridge between 2 and 8 degrees, and it will extend its life. And that's where we would like it to be. Once it comes out of the fridge, though, it's good for a month. So this is where if you look at your insulin and you do not store your insulin at room temperature, it must be stored in the fridge for it to last for 6 months, okay, on the best before date that's there. So insulin is always refrigerated. Once it's taken out of the fridge, you have a month to use it. And for most diabetics, that's why you can leave the insulin on the table. Now, good practice is that you actually label the date that you took it out of the fridge, so you don't use it longer than a month. Okay, and as nurses, you should be doing that, labeling the insulin of when it was taken out of the fridge. So the Levemir is exceptional. It is safe in the room a little bit for 42 days, which is nice. So it's gives you a little bit more. Keep all insulins away from direct heat and light. Discard insulins that have frozen or been exposed to temperatures greater than 30 degrees. Do not use insulin after its expiry date, even if it's been in the fridge. Some adverse effects of using any type of insulin. Lipodystrophy basically means buildup of fat in the injection area. You can have an allergic reaction to it. You can get insulin resistance, unfortunately. And the biggest thing is hypoglycemia. Okay, too much insulin, and as we talked about this in pathology, when we talked about hypoglycemia, omission of a meal, excessive exercise because of increased sensitivity, or a error in the dose, okay, or the measurement of insulin. Let's say you're mixing up cloudy and clear and you've been contaminating your fast acting. That would be an error in dosing, okay? Or the nurse drew up 4 units of NPH instead of 3. That's an error in dosing. It can also be enhanced by some other drugs, aspirin, sulfonamides, and anticoagulants. Can actually enhance its effects. And sulfonamides is important because when we talk about a drug that is for type 2 in the next lecture, guess what? That those drugs that help us to drop our blood sugar in type 2 diabetics are sulfonamide-based, sulfa-based drugs. Any sulfa-based drug is a sulfonamide. It will actually enhance the effect of insulin. Insulin delivery devices. So this is we're going to talk about how you actually deliver these, and this is not in your textbook. This I've made up so that you understand how these work. We have insulin needles, insulin pens, and insulin pumps, and I'm going to try today at home to do a little video with my phone or my GoPro and see if this, how well this works. So insulin pumps, insulin pens, insulin pumps, and insulin needles. This is a needle, this is an insulin pen, and this is an insulin pump. Okay, insulin syringes are marked differently. Okay, if you look at them, even though they do not have a specific volume on it, they are marked in units. Okay, units on an insulin syringe correspond to units of insulin. So there's no, oh gee, how many cc's do I have to give this amount of insulin? And every drug company has mixed their insulin the same way so that you know that if I draw up in an insulin syringe 2 units of let's say Humalog, that will give you 2 units of Humalog. If I use an insulin syringe to draw up 2 units of Apidra, I will get 2 units of Apidra. So there's a common dosing that actually occurs with this, and the insulin syringes and drug companies then also make their concentrations standardized to match these syringes, and so that actually helps. The plunger is also different. There's no bevel on this insulin syringe, and there's no meniscus because of that as well. Let me show you what that means on the next slide. This is a regular syringe up here at the top. Notice there is no bevel on the plunger. This is a bevel, okay? And therefore, if there's no bevel, there is no what we call meniscus to worry about, okay? Look at the insulin syringe over here, straight, okay? This is an insulin syringe here too. It is straight, okay? There is no bevel on the plunger, which means there is no meniscus. Meniscus is, hey, this is the amount up here, even though I've drawn up to here, it's actually up here that we have to worry about. So in an insulin syringe, straight, no bevel, no. They've made the insulin syringe particularly this way, so you do not need a bevel within the plunger, and you do not need a meniscus. And as we see, it says unit dose. This is in units. Okay, this is why I've shown you this one here as well. And this is 100 units, and we can get insulin syringes down to 30 units. And this is what we see. And now there is a volume that goes with it. We would say that there is 0.3 mLs in here, but you don't need to worry about that. What you need to know is that insulin unit syringes come in different sizes. They come in 30s, they come in 50s, and they come in 100s. Obviously, the smaller dose used is better for pulling up more precise doses, and primarily these ones are used in pediatrics, and as they get older, then you can use the 50 and 100s. And notice also the gauge is different, so meaning the needle gauge, you know how thick this is and how long this is. So we will have a 30 unit syringe can have an 8 millimeter long needle on it, and that 8 millimeter long can be a 30 or a 31. You can have a longer syringe if you happen to be a fatter kid. I hate to say it, but more fat tissue means that you need a longer syringe or a longer needle, and you can have a 12.7 or 1.5 inch long needle that is a 30 gauge or 29 gauge. Okay, and as the number gets lower, the thickness of the needle gets bigger. Right? So in thickness of needles, a higher number always means a thinner gauge needle, okay? And a lower number means a thicker gauge needle. Implementation and use of the syringe. Pinch gently up on the skin and fat with your thumb and forefinger. Hold the insulin syringe like a pencil, okay? And hold it close to the needle edge for better control. Push it in quickly at a 90 degrees, okay, on the pinched up level. Push the plunger all the way in, then slowly let go of the pinched up skin, remove the needle. Okay, notice I just didn't inject it. Notice we didn't do the following. Notice we didn't inject, okay, and then pull out right away. You inject, release the skin, then pull out, okay? And use a dry swab, gently apply pressure, do not rub it. Insulin pens are a little bit nicer. The reason being is that everything the insulin is contained within the pen. You don't have to draw up, you don't have to look at anything like this. You dial up your amount, okay, you dial up the amount, and that's the amount you are going to give. It takes away a lot of the sight looking and seeing, especially giving smaller amounts. Some of the insulin pens can give a half a unit. That's very important. If you look back on the previous slide, when we looked at those insulin syringes, if I needed to give a half a unit, that's damn hard to give even on a 30 unit syringe. You have to look sort of in between, did I give a half, did I not? So the insulin pens are quite useful this way. There's no drawing up out of a tube and everything is self-contained. You can put it in your pocket. All you need is a needle tip to go on the end of it, and you can give yourself your insulin. You just dial it up and give it. So it's especially easier to use, especially for those for older adults. Okay, you know right now trying to draw up medications how much of a pain it is to get out all the bubbles and to try and draw it up and do an insulin syringe and everything. It takes some skill. What if you have arthritis? It's going to be a real big pain. So it's easy to use, especially for those for reduced dexterity. Little or no instruction that needs to be done with it, and I'll show you how later on. Improved accuracy for those smaller doses, some of them up to a half a unit. It's more socially acceptable to just see somebody pull a pen out and do an injection. Can you see what somebody uses an insulin syringe? And it could be, is that insulin you're giving yourself? You're giving yourself some heroin. It's more socially acceptable. Less injection at the pain site, and it's much more portable. Okay, I just have to take some insulin tips, and as I said, I'll show you later on. Yes, I would expect you to know the advantages of using an insulin pen. And this is what they look like. The insulin is on the inside over here in a cartridge, okay, and then we have this big long cartridge over here, or this big long pen, and you can dial up the amount of units you're going to give. The only thing you change on here is the needle, and it's a screw-on needle tip. So it's very easy to use. This is just an exploded view of a pre-filled syringe. So this is what the insulin pen looks like. It needs a needle tip that gets screwed on the end over here. So this gets screwed on over here. Okay, and then you see you can dial up the amount of units that you need. Now the one thing you do need to know with an insulin pen is you do need to prime the needle once it's on, and what that basically means is you dial up 1 or 2 units and waste it so that you actually see that some insulin comes out of the end, and then you dial up your dose and give it the same, and basically give it to yourself. So these are very, very, very easy to use. And look, you can use 50-50 doses of rapid acting and NPH. You can use regular NPH. It can also be used for it can also be used for the long actings as well. These are leaps and bounds above giving yourself an injection. Okay. Insulin pumps. What is an insulin pump? An insulin pump is a small computerized device with a pump and a reservoir in it that basically gives you insulin subcutaneously throughout the day. It is always running. Like I said in the class, it is like giving there's like a constant IV infusion going on of a small amount to meet the basic metabolic needs of the patient. My daughter upstairs right now is running at 1 cc an hour. Okay, that is what she is running at for with her insulin pump. The reason being is that is meeting her basic metabolic needs. When she eats, she gives herself, over and above that basic metabolic need, she gives herself a bolus of insulin that matches the amount she's going to be eating. By doing this, you eliminate the need for long-acting insulins, you eliminate the need for intermediate-acting insulin, okay, and it works more like your own pancreas. It's an on-demand sort of system, okay, which is why we were saying it attempts to mimic the normal release of insulin in your body, which is also why we like to use the rapid-acting insulins, the ones that onset very quickly, within 15 minutes. So having said that, this is where these terms come from. There are 2 things that work on an insulin pump. The basal rate, which is continuous. It is that continuous IV, for lack of a better term. Somebody said in class, hey, is it like a continuous IV going? Yes, but it's a continuous subcutaneous infusion going on. So 24 hours a day, there is a basal rate going on within your body, or through the insulin pump. It's always on, okay, meeting that basic metabolic need. And then when you eat, you get a bolus over and above what the basal is giving you to cover you for that spike in blood sugar when you eat. And these are what these look like. There's a Minimed. This company, this one here has actually gone out of business right now, and you won't see Animus pumps anymore. You'll pretty much see you will see Medtronic, and you will see Omnipod from now on. These are pretty much going to be the only 2 pumps in existence in Ontario. Okay, and so one of the things we're going to see here is we have we have some advantages of the insulin pump over actually using injections. So whether or not somebody chooses to use one or the other, it's pretty much up to their lifestyle, up to their lifestyle choice, and whether or not they want to use use a pump or use injections. And you'll see when we talk about the advantages and disadvantages of a pump, why it's actually some people may choose one over the other. A lot of people prefer the pump. It has a lot more advantages with regards to diabetic management that people like, but it does have some downfalls that people do not like as well, and it all depends. That will come down to personal preference. But the advantages, yes, and I would expect you to know the advantages and disadvantages of a pump. The advantages of a pump is it eliminates the injection and unpredictable effects of intermediate or long-acting. The NPH, I've sort of said, it depends on the person. Sometimes you don't, it's not uniform how long the NPH will last for, and sometimes even peak, and it's a bit of a pain that way. But more importantly, when you give yourself a long-acting or intermediate insulin, there's a problem, and specifically if you're using it for the basal rate. Okay, so if you're using it for your basal needs in your background, long-acting and intermediate insulin, you cannot take away once you've given it. And good example of what I mean by you cannot take it away, what happens if you're an injector? You give yourself some Lantus in the morning, okay, and it lasts for 24 hours, and in the afternoon you decide you want to go for a jog, okay, and say, hey, I want to exercise this afternoon. I got some time off. I'm going to go to the gym and work out. Insulin sensitivity, you become more sensitive to insulin. You can become more sensitive to insulin during exercise. What do you think happens when you go to the gym? Even if you don't bolus yourself with rapid acting before, what do you think is going to happen? You're going to go hypoglycemic. Your body is going to become more sensitive to the Lantus that is in your system right now. Your basal needs are going to change, and you can go hypoglycemic. Okay, just from the Lantus that's sitting in your system. So that's a problem. Okay, and what does, and you're going to say, well, what does that mean, that injectors can't exercise? No, it just means that they have to take their sugar more. They have to take their sugar more often, and they might have to, before exercise, take a loading dose of sugar without any rapid acting insulin to go with it. So a lot of patients I know who go to exercise, what they do is once they start exercising, what they do is they will take probably 20 or 30 grams of sugar, not give themselves any rapid acting insulin, and they will take that sugar prior to exercising, knowing that the long acting insulin that they gave themselves in the morning, they're going to become more sensitive to it during the exercise. And that basically means that, you know, that's a problem. Okay, that means you have to take more sugar when you're working out. So that can be a problem. Okay, and that's where but when you take a pump, what a pump does is, guess what? I said the pump is always running short-acting or rapid-acting insulin in the background. No delayed response. What does that mean? If my daughter goes to decide and run around the block right now, do you know what we're going to do? We're going to take her pump, and we can adjust the basal rate down. We can cut it by half if we need to. We can cut it by more than a half. Okay, we can turn it from 1 unit per hour down to 0.3 units per hour if she's working out really, really hard. And we've had to do that when she's done track and field. So it's very flexible that way, and that's one of the big thing about the insulin pump that we like. It also delivers insulin more accurately, and I will show you can give up to 0.1 of a unit. You can't get that with an insulin. You can't get that even with an insulin pen. Insulin pens only go to a half unit. This we can give units down to 0.1 of a unit. Very, very accurate. And with this, pumps have been shown, because of these two things, they have been shown to improve A1Cs. Also, it also results in fewer large swings in blood sugars because you're always giving it, because you have that flexibility. It makes delivery of boluses much, much easier. Okay, because it's computerized, you can basically go in and you can just put in your carbs, and it will just you have pre-settings already in it, and already preset give you stuff. I'll show you how that looks like later on. Flexibility in eating patterns. I don't have to eat all the time at the same time every day. Why? Because I got this pump. I don't have to use intermediate or long acting. I don't have to use any intermediate. I can wait and wait and wait, then, you know, if I skipped lunch or whatever, doesn't matter, I got my basal running, I'll eat lunch later. Give yourself your food later on. It also reduces any severe hypoglycemic events due to what we call stacking of insulin. And I'll show you what that means later on as well. And it's very adjustable when activity rises, and this sort of ties into this one as well. So when activity rises, or if you're sick, you can disadvantages rate, you can cause weight gain. You don't have to wait
you want, whatever
24 hours to give yourself
higher risk of
diabetic ketoacidosis. Why? Because as I said, and this is where looking at one of the questions on your assignment right now, higher risk of diabetic ketoacidosis because we only use rapid acting in it. And you are using a pump for your basal metabolic needs. If I turn off a pump, rip the pump away from you, take your pump away, break it, and it is not infusing any more insulin, 1 unit an hour is what my daughter is getting for her basal rate right now, and I rip that away from her. When does that 1 unit per hour wear off? 4 hours from now. So that means in 4 hours, she has no insulin in her body. Within 4 hours, she will start to, the process of her body of going into diabetic ketoacidosis will occur. You can slip into DKA very quickly when the pump is turned off or taken away from you. And having said that, when you look at look at your assignment, I said, which one would you need to worry about, the one on a pump or the one on injections? Who got, and you'll see that the difference in the question is you have 2 patients, one whose pump has malfunctioned and one who's got their long-acting insulin in the morning but not their rapid. Okay, got their long-acting in the morning but not their rapid. Which one is the priority for you to go see and find and fix? The one that is not going to go into DKA the quickest. An injector who doesn't give themselves enough rapid in the morning and skips their rapid injection, but gave themselves their long-acting Lantus in the morning, will they be in diabetic ketoacidosis 8 hours later? No. Will they be hyperglycemic? Yes. Will they be suffering from the effects of hyperglycemia? Yes. But will they actually die from this? No. Okay. Not unless they just keep eating and eating and eating. But the patient who is on a pump, you remove that pump, they will start slipping into the process of DKA will start to occur within 4 hours. Not good. All right, so that is why they're at higher risk for diabetic ketoacidosis, okay, and that is the system fails. It's also freaking ass expensive, $5 grand it's $5 to buy a pump, minimum, and then you have to put in the monthly supplies, and monthly supplies can run you $300 or more a month. It's expensive, okay? And this is why patients are always worried about their hemoglobin A1C. You know why? Especially if they're on a pump, because if your hemoglobin, the government will cover this outset of cost. Every 5 years you can buy a new pump, and the government will pay it off if, and only if, your hemoglobin A1C, which is an indicator of how well you are managing your diabetes, if your hemoglobin A1C stays at 10 or below. If it is 11 at one visit, and then 11 again another visit later, guess what? They will take the money away from you. Okay? So that's why pumpers are always concerned about their hemoglobin A1C. They don't want the government to remove the subsidy because it's a lot of money. It can be annoying because you got this pump and this string and this tube attached to you, and it does require more frequent blood sugar testing, because the way this pump works is it works really well and you get tight control the more information you feed it. Okay, so you're always feeding it as much information as possible and doing as much corrections as possible and everything, and this will work very well for it. Okay, but it means you have to test more often. My daughter tests sometimes up to 10 to 12 times per day. Okay, she tests 10 or 12 times per day, and she for her diabetes when she's on a pump. When she wasn't on a pump, she could test 4 or 5 times a day. So it's almost like sometimes you can double the amount of testing you're doing. And unfortunately, this won't be offered anymore after this year, so I'll have to change the slide. But you can even have ones where you've got this animus pump, and they even have situations right now where you have a remote that goes with it, where you can actually test your blood sugar up here, and then you will actually and then what will happen is it will then transmit that information to the pump, and the pump will use that blood sugar information to actually calculate doses. And look down here. I want you to pay close attention. Look down here. Basal rate. This thing is running at 0.025 units an hour. This is what you would give a baby, okay, if you had a baby on a pump. And it has 100, and you carry around with you 177 units in the reservoir that's in here. Okay, so this is really quite cool stuff. This is also what's come out that's become very vogue. This is an insulin pump. This is a Medtronic insulin pump, and this is the tube that goes subcutaneous down here, and I'll show you what this looks like underneath this area right here. But the other thing that's very cool is they now have this thing, and you're not responsible for knowing this, but they now have something called interstitial blood glucose, or interstitial glucose monitoring, and this is a sensor that is stuck interstitial, and it has been calibrated to say if your interstitial sugar is this, then it will relate to a blood sugar of X. Okay, and this thing communicates directly with the pump, and you have this constant communication going on where this is measuring your interstitial sugar, sending information over here, saying, hey, you need to give more insulin, or hey, you don't need to give more insulin. And it's very cool. You can actually monitor your patterns of how your blood sugar goes up and down every day. This is what underneath, so I said I would show you what the tubing going into the interstitial catheter, and this is my daughter when her daughters actually came out the one day. You have this catheter tube that comes up and goes into a little site, and what happens is, if you look very closely here, what happens is it goes into this little area here, and there's a little catheter that goes right underneath the skin, just like a needle injection would be, and it slowly, as I said, if we're running a basal rate, then that means there's going to be a constant flow of insulin going subcutaneous here. And these sites can last up to about 3 days, and every 3 days you rotate the site that you're using. And that's the little catheter that I was telling you about right there. And people use this in all different shapes and forms and places. You know, and you can stick it on your thigh, you can stick it on your arm. This girl that I was working with, she liked to wear it on her boot because she liked to stick it in her thigh up around her butt. And some ladies will wear these in their bras because they'll have it on their arm. So it's a very cool sort of, you know, and it almost becomes vogue. Here's my, you know, kids who have pumps will actually brag that they have a pump, you know, because in the age of cell phones and stuff like this, this has become very cool. Okay, so one of the things is, can you spot the diabetic pumper in the room? Can you spot the diabetic in the room? There is probably somebody who was in our lecture the other day who was a diabetic. Okay, you can't notice it. The one thing about diabetes is diabetes is an invisible illness. Okay, diabetics go around, and a diabetic in the class who's an injector might excuse themselves and go to the washroom, go into a stall and inject themselves and then come out. And you would never know that they're diabetic. With good management, you would never know that somebody in the room is a diabetic. So putting this all together, let's talk a little bit about some of the insulin therapies. Goal of insulin therapy. Okay, talking about the delivery devices, talking about the different types of insulins. We've already sort of alluded to all of this together. And this is where we want to control insulin, and we want to give insulin regularly during the day. So we want to control our insulin blood sugar levels. We want a peak of insulin or a bolus of insulin when we're eating, and we want less, and we do not want a bolus, and we want lower levels when we're fasting. Okay, we want to decrease our metabolic rate. As I said, there is always a need to have this basic metabolic need. For even if you're fasting, you have to have some insulin on board. As I said, with the injectors, we can use multiple doses of intermediate, or better yet, let's use the long-acting ones to meet that basic metabolic need. In a pumper, we have a constant low infusion of insulin going with the pumper, and that is to meet that basic metabolic need that is always going on in the background. Okay, when you eat, your blood sugar peaks, and you've got to shift that blood sugar very quickly, and that's when you get a bolus. So this is where I say you get this low background going on, and that is the basal rate, and you get peaks to match when you're eating and spikes in your blood sugar. And what we're trying to do is we're trying to mimic what the pancreas would do on its own. Remember, there's always an interplay between glucagon and insulin. Okay, when you're fasting, your blood sugar never goes to zero, or shouldn't. The glucose is released, so this is why you always need insulin in the background to maintain that amount. That's from pathology. I'm just reiterating what I just said on the previous slide and what I mentioned a couple of times already. You need a basal rate to maintain so that cells do not go into DKA. All right. Factors that affect that basal metabolic rate: exercise, which we've already talked about. Exercise will increase your sensitivity to insulin and cause hypoglycemia. Illness will cause hyperglycemia because with the counter-regulatory hormones, you will see spike in blood sugar because your body is releasing its stores. We will also see some normal daily fluctuations due to cortisol levels going up and down, and we will see that people need sometimes less basal, will decrease their basal rates at night. This is why people like Levemir when they're an injector, because they will take a larger dose of Levemir that will cover them from 8 until 8 at night, and then at nighttime they will take a lower dose. Why? Because they're sleeping. They don't need as much. Okay? So we want to mimic the daily pattern, and this is the biggest challenge for a diabetic, knowing what their daily pattern is, and it's unique to each diabetic. So this is where the challenge of dosing comes in. Insulin patterns can be mimicked using, as I said, a combination of short-acting, or short-acting, long-acting, or intermediate, and an injection, and in a pumper, only rapid. Challenge for the diabetic patient is that other regulators of blood sugar are still functioning and respond without our control. This is those counter-regulatory hormones, insulin, glucagon, and our diabetic management has to sort of predict when these occur and react to when these do occur. Right now I have my wife has given my daughter her cold, that person who was coughing in the last lecture. Well, now my diabetic daughter is coughing as well. Well, I'm cranking up and giving her more basal rate right now, and she's not eating as much. Okay, so she's getting fewer and fewer and fewer boluses of food, boluses of insulin, because she's not eating as much, and I've actually cranked up her basal rate, and all she's doing is sleeping. So it goes against what you would normally think in illness, right? Because you're thinking, hey, as you're sleeping all the time, but you're requiring more insulin. How is that possible? Well, because of the counter-regulatory hormones that are shot out because of illness, then we have to respond to that. I have to respond by giving her more basal rate of insulin in her pump. And there are individual differences for each patient that have to be addressed when you're actually creating this insulin regime. Now, there are some things that you need to be aware of when somebody is being given insulin. So there's some terminology you have to need for a pumper or an injector. There are certain factors that you need to know or need to understand, and they are things that are what we call individualized factors within each patient. We have something called an insulin sensitivity factor, which is an ISF. This is also known as a correction factor in patients. And the definition of this is how much insulin you need to bring your blood sugar down, the sugar that is presently in your blood. Okay? It's defined as how much 1 unit of rapid-acting insulin will lower your blood glucose over 2 to 4 hours in a fasting or pre-meal state. So this is an example that you could have for somebody. My insulin sensitivity factor means that 1 unit will bring my blood sugar down 5 millimoles within 2 to 4 hours. Or 1 unit will bring my insulin level, my sugars down 3 millimoles within the next 2 to 4 hours. Okay, and what that would mean that is, say for example, my blood sugar, say I have a blood sugar. So if my insulin level, let's say I have an insulin ratio of 1 to 5, an insulin sensitivity factor of 1 to 5, and my blood sugar is 10. You want to bring my blood sugar down to 5. How much do I need? 1 unit. Let's say my blood sugar is 15, and I have an insulin carb ratio of, I have an ISF of 1 to 5. How much do I need to correct my blood sugar back down to 10 if my blood sugar is 15? I want to bring my blood sugar down 10 millimoles, so that means I will have to give myself 2 units. Simple, okay? But we call this an insulin sensitivity factor, or we call also known as a correction factor. How do I correct my blood sugar down? Now, that is different than what we call an insulin to carb ratio. People get these two things confused. An insulin to carb ratio means if I eat this much carbohydrates in my meal, how much insulin do I need? Okay, what will that translate into my blood sugar? Because the difference here is this is what your blood sugar actually is. Here, it would take too long for me to go, hey, I wonder how much insulin I should give myself for that Big Mac, I'm about to eat. Well, I'll eat the Big Mac, and then in 2 hours I'll take my blood sugar and then just use my correction factor to correct my blood sugar down. That's chasing blood sugar levels, 2 to 3 hours away, and that's not meeting peaks and everything. And in that period of time, you're going to become symptomatic from hyperglycemic symptoms. So it's not a good thing to wait until your blood sugar peaks and then give yourself insulin. What you want to be able to do is you want a ratio and decide, hey, if I have this much carbohydrates or this much sugar in my meal right now, how much insulin will I need so that the peak of my blood sugar matches the insulin that I'm going to give? And this needs a little bit of, and this needs what we call a little bit of experimentation when somebody is first diagnosed. But what it means is that when we eat certain carbs, those carbs translate into simple sugars in our blood. And with a little bit of experimentation at the beginning, you can get an idea of what your carb ratio is. So for example, if I eat 10 carbohydrates, and you look on the packaging and it says there's 20 carbohydrates in this food product. So if I eat 10 carbs, I need 1 unit of insulin, because whatever those 10 carbs translate into blood sugar, I will need at least 1 unit for it. So we call this a carb count. We say that we need an insulin carb ratio. This is different than the insulin sensitivity factor. Okay, please do not get these two confused. Yes, I will ask a question of it on the test. So as I was saying, do not confuse these two together. Okay, they are different ratios that are used to actually manage diabetes, and they are different for each patient. Okay, so insulin sensitivity factor and carb ratio, two important things that you will need to be aware of. Now, when we look at the goal of insulin therapy, as I said, we're trying to mimic normal physiological insulin response. And this is the diagram we have here. We have two things happening. We have the line right here, which is the blue lines, okay, where you see a line going right across here, and then you see a hump, another hump, and another hump. This is delivery of insulin. This is actually a diagram of insulin being delivered by an insulin pump. Okay, in the background here, you see this white stuff here in the background? All this white over here like this. Okay, so what this is this could be, you can look at this in two ways. You can look at this as You can look at this as blood sugar in the background. The blood sugar spikes and then comes up and then comes back down, and then blood sugar spikes up again after eating, comes back down, and then the blood sugar spikes back up and then comes back down again. So the white in the background, for our purposes, we'll talk about this, that this is actually your blood sugar spiking in the background. And what we want to do when we say we want to mimic insulin that's released, and these spikes in the background, if this was your normal, pancreas working, your pancreas would basically spike insulin in the background like this. Okay, and it would do this to take care of the sugar that is going up in your body. So the background white here is actually what your normal is the optimum rapid acting profile, and this is the profile. The white in the background is what your pancreas would be doing and responding with insulin if your pancreas is working. So all of you sitting here without diabetes, your insulin profile in your background, okay, your insulin profile. Let me take out the word background there because that'll confuse you. The insulin profile from your normal pancreas would look like the white here. Okay, that's the white. What we have to do, unfortunately, we cannot make that. We haven't gotten to the point where our insulin therapy is as precise as this, but we're pretty close. Okay, what we do is we try and mimic what's going on with an insulin pump. We give a constant basal rate, boom, and then we have breakfast, and we give ourselves a bolus over and above what the basal rate is, and then another one here, another one there, and notice that this profile of insulin in the blue here that's given by the pump is we're trying to match the same spikes that your body would already do, okay, during the course of the day, and we're also trying to match the basal amount that's always running in the background. So this diagram, and I apologize for the one person I think I told something a little bit different to. I think I told somebody in class that this is actually blood sugar in the background. It's not in this diagram. What the white is the white is what your body would release in units of insulin in a normal acting kidney. So in the background we have, normal acting pancreas. So in the background, the white, okay, the white spikes in the background here, okay, is the profile of insulin from a normal kidney, a normal pancreas. The blue lines right here are what we're actually trying to mimic using an insulin pump and or using injections. Now, some of the things you might need to know, in particular, we talk about injectors. You will see written for some of your patients a sliding scale, and with this sliding scale, guess what they use? They use that insulin sensitivity factor. Okay, so here we see changes, and we give 2 units here when blood sugar is between 8 and approximately 12. So how many is between, and we want our blood sugars to be, and look, the very first one here is between 4 and 7.9, or between 4 and 8, give nothing. Okay, so right there, that's the range that the doctor wants this patient to be at, between 4 and 8. Now, if you go up and you go over 8, you go 8 to about approximately 12, that is a difference of what? What's 12 minus 8? 4. And when your blood sugar is off by 4 millimoles, this doctor wants this patient to get 2 units of NovoRapid, 2 units of a fast, rapid-acting insulin. So I wonder what their ISF is. 4 blood sugar level is above what we want it to be by 4 units. Okay, we want it to be below 8, and we go 8 to there. That's about 4. So and we have to give 2 units to bring it back down to 8 or below. 4 divided by 2 is 2. 1 unit for every 2 millimoles of blood sugar. So this patient has an insulin sensitivity ratio of 1 to 2. And if you look at the rest here, it will all make sense. Okay, if you look at the rest here of above 8, 16. Oh my God, this patient has gone from 8 to 16 pretty much. So if we go 16 minus 8, and we have an insulin sensitivity ratio of 1 to 4 or 1 to 2, then that means we have to give 4. It makes sense, okay? And as you keep going up each slide here, you'll notice that for every 2 millimoles above the patient's ideal ideal blood sugar, you have to give a unit of insulin to bring them down. Now, please note that below 4, for most patients, it will say call the physician and treat with glucose. The other thing is anything over 24, this is where you need to call the physician as well, because the scale only goes up to 24. After 24, they have to consider whether or not there's anything else adverse going on with the patient. I already talked about insulin on board, and I showed you that diagram with that as well earlier in the lecture. So it's a term to use to describe how much insulin is still active in the patient's body, and I showed you on that previous diagram why, and that's why this lecture is a little late, because I realized that this is probably not sufficient for people to understand what I mean by active insulin. But now that I mean the part of the insulin curve that is still above the minimum effective concentration line, that is insulin on board. Okay, and in more particularly, when we're talking diabetes, we want to know the amount of insulin that is still remaining after the peak. So above the minimum effective concentration line and after the peak of insulin, that is what we call insulin on board. And this term helps us deciding when you need more insulin or when you need more carbohydrates. Okay, insulin stacking, as I sort of went over in class, this is an accumulation of insulin in the blood due to overlapping insulin dosages. Although when giving antibiotics and stuff like that in the first lecture, as I said, we kind of want to do that to bring you up into a therapeutic range. We don't want this in diabetes. Okay, in diabetes, it is not what we want. We do not want to be stacking doses on top of each other. It will result in hypoglycemic moments. So this will help you a little bit when we're talking about. This will help a little bit when you look at your assignment. Okay, so we look at if we're for an injector, what we would be doing for them, and this is where on your assignment, look on your assignment. Do you have a constant line basal going on in the background? No, you have overlapping little curves like this at the bottom. This is your basal amounts, okay? Here we have a basal starting here, and there's a gap in here, and then there's another one here. So long-acting insulin will always look like these small little humps in the background. So when you're looking at your assignment right now, do you see a solid line right across that mimics, like the previous diagram about 2 slides back when we were talking about mimicking? Do you see a constant line in the background that indicates that there is a constant infusion of insulin going on? It's a rhetorical question. The answer is no. Do you see some little humps like this in the background? Yes. Are they overlapping the way they and to a certain degree so that you get coverage right across the board in all 3 of these diagrams? Pretty much, except for this one here, pretty much you have overlapping of these long-acting insulins in the background. Also, do you have a peak that corresponds with meals? Yes, you do. Okay, in all 3 of these. So what we have here is we have patterns of what we would call for injectors. How many insulin injections they will have per day. It will depend on what long-acting insulin they're using and how often they eat. Okay? In this one here, look what's interesting here. As this person here has to eat, breakfast, lunch, and then dinner, and then the next day breakfast, and there's this one insulin here that just sort of goes from here and then goes over, and there's a little bit of time when it's not active. That's probably your Lantus right there. If we look at one here that goes from breakfast to about midnight and dies away, guess what? That's probably Levemir. And then another one that goes from here to here, from dinner to breakfast. That's going to be Levemir. That's a 12-acting hour one. Similar here, you have a 12-acting insulin as well. Here, because it goes from bedtime all the way through, and this ... means it's going to continue and continue on here and continue. That's Lantus. So you can get 2, 3, 4 injections per day when you're using some of these insulins, okay? And actually 2 is not really, 2 injections a day, depending if you only eat 2 big meals or whether or not you're going to have, you could get 2 injections a day. You could skip an injection if you use an NPH as well. So there's a lot of things that you can do with an injector to get this pattern. But the common thing in all of these is you have some insulin running in the background, usually through a long-acting, and then you have spikes of rapid to actually. So implementation insulin is on a list of hot drugs that have a high incidence of medical errors. Why? Insulin sometimes is given, as we talked about with injecting, in anticipation that blood sugar is going to rise because you're going to eat. Okay, so sometimes you can get that mimicking can come out of sync, where you're not actually having your peak of your insulin with your peak of your blood sugar. Onset and action don't always coincide. Okay, sometimes you can get, and stacking is a big problem here, where I decide, hey, I want more food, give myself more insulin. Yeah, but you know what? You haven't peaked yet from your previous dose. Or, so that's a problem. Small amounts can mean a big difference. Okay, so 1 unit decreases by 5. There are people that have 1 unit. My daughter, when she was a child, 1 unit decreased her by 8 millimoles. Okay, each patient is very different. So if you screw up and screw up your ISF or your insulin carb dosages, you can screw up and overdose or underdose. Nursing error is another thing that can happen as well. And using combinations of different types of insulin to match daily patterns. Okay, so this is if you're giving, NPH, you're giving rapid, you're giving Levemir or Lantus, you're using all 3. Guess what? Lantus and Levemir Lantus, Levemir, and rapids all look like clear insulins, and I've had people screw up, and they're given in pens. I've actually seen where a patient has given themselves, at diabetes camp, we had a kid who gave themselves, they were supposed to give themselves a bolus of rapid acting, and by mistake they gave themselves a bolus of Levemir. So they gave themselves too much Levemir. Well, the problem is that Levemir, so basically we just let the kid run high all day because their blood sugar spiked, but they didn't have enough rapid to take care of it, but they had all this Levemir on board that was going to last for 12 hours. So that was a pain in the butt. So you can easily make common errors. Sometimes you don't inject properly, which can cause errors as well. Assessments, each dose, pre-administration of insulin. So with each dose, before you give a dose, you need to check your insulin, or you need to check your blood sugar level. Okay, current data, whether or not you're an injector or whether or not you're a pumper, you got to check your blood level before you give yourself some insulin. And also assess for any signs of fever, vomiting, or diarrhea. Because guess what? If you're about to give yourself some insulin and you're nauseated, you might not want to do that. You might want to hold off on your meal until the nausea goes away. Because if you give yourself insulin and then go and eat your meal and you start puking, guess what? You're going to go hypoglycemic. Post-administration of insulin, always check for signs of hypoglycemia, hyperglycemia, or any allergic reactions. Hypoglycemia and hyperglycemia, the signs and symptoms are, I won't test you too much on this, but they are different for every patient, and their patient may experience one or several of these. Most of them, when they're hypo, feel hungry. depending on what other ones, like for example, my daughter gets the shakes and she gets anxious and dizzy. Other people will sweat, have a fast heart rate, or feel fatigued, and some get a headache, some get irritable. There can be one or several of these symptoms for hypoglycemia for a patient. For hyperglycemia, oh look here. You notice a little problem between the last two? Oh look, you can get blurred vision and hyperglycemia. Well, you can get it in hypo as well. Oh, you can get drowsy with hyperglycemia. You can get it with hypo as well. Oh, you can get hunger. You can get hungry with hyperglycemia. Oh, you can get that with hypo too. The one thing that is, the two things that are very, it happens with hyper and not with hypo is frequent urination, extreme thirst. Okay, those two things for sure always happen. Okay, and again, patients can exhibit these symptoms, or they can exhibit one or several of these, depending on themselves. As I said, with the long-term management, we use the hemoglobin A1C, and it basically gives you an idea of what your fasting blood glucose should be, or what your average managing blood sugar is going to be, and we want to get that as close to 7 as possible. And diabetes knowledge and attitude relating to their condition, always take their history as well, assess for diet and activity, skin and mucous membranes, and check the injection sites as well, and make sure you rotate injection sites. Education, all the sort of things you need to do: diet, exercise, avoidance of alcohol, foot care, glucose testing, wearing of their proper ID bands, making sure that they take their anti-diabetic medications, and the proper hydration, and make sure they know how to treat for hypoglycemia. Okay, and last, there's a couple of slides here we just need to make you aware of. Yeah, they are kind of important, but they're not that difficult. So, glucose elevating agents. So for type 1 or type 2 diabetes, there are a couple of things that we can use if you go hypoglycemic. So we've been talking about insulin all the way here through bringing down blood sugar, but something that will work. Something that's called blood sugars, which are basically dextrose. Dextrose is the simplest form of sugar. It gets absorbed rapidly through your mouth and through your GI tract. We can also give IV or subcutaneous dosage of glucagons. For IV purposes, we can give straight sugar and water IV as well. And there's this other thing called dioxyl-proglycem, which is a thiazide derivative, which inhibits pancreatic insulin release and thus increasing blood glucose level. What do you think this one will be used? Type 1 or type 2? Take a wild guess. Thiazide derivative, which inhibits pancreatic insulin release. Inhibits the pancreas. Type 1s, I know, did you get it right on pathology or not? Type 1s produce no insulin. Type 2s produce insulin still. So dioxyl-proglycem primarily for type 2 diabetics. Glucagon, we've talked about glucagon infinitum in pathology. So the main thing that you need to know with this is it can be given for severe hypoglycemia where somebody has basically passed out. The one part that we did not talk about in pathology, which is important, is that can only be used when glycogen is actually available in the liver. So if somebody is in starvation mode or adrenal insufficiency, glucagon will not work. Okay. You have somebody who is an anorexic, or somebody who has been starving in I'll be very dramatic here. Somebody who's starving in a concentration camp. Would glucagon work on them? No, because they have to have glycogen stored somewhere in their body for glucagon to work. So for somebody who has not been eating normally, somebody who's in starvation mode, somebody who has adrenal insufficiency, they will not be storing glycogen, and then therefore they will have a problem. I'll give you an example, but it just shows you there is a group of patients I get at the hospital who have metabolic disorders. And they have something specifically called glycogen storage disease. So, as we know, you start puking, you're sick or whatever like this, glycogen is activated, glycogen from your stores is released in your body, and you don't die. My example of what I talked about in lecture saying, those of you who skipped breakfast this morning, why aren't you dead? Well, it's because you have glycogen stored in your body. You can store it. The group of patients that I have at Sick Kids who have glycogen storage disease can store no glycogen whatsoever their entire life. It's a genetic malformation. They can't do it. They start to vomit. They could go hypoglycemic and die within hours. Okay, they can get they can go into acidosis. They can die very, very quickly. So, and the reason being is because they start getting sick. They can't produce enough. They can't produce enough sugar or release enough sugar in their body to meet their basic metabolic needs. Glycogen storage disease. It's a very rare, but it's a very good example of where glucagon would not work on somebody who does not have any glycogen in them. The hyperstat or the dioxyol, whatever this one is, a prompt dose-related increase in glucose levels, basically inhibits the release of pancreatic insulin. You would only use this on a patient who has type 2 diabetes and who has in a situation where they are hyperproducing insulin. And this is what hyperstat looks like. Okay, it comes in what glucagon looks like. Hyperstat comes in an IV form like this. Glucagon, which you need to be aware of if you're working with diabetic patients, we basically have a powder in here. We have a glass syringe that has water in it. The water goes into there, reconstitutes. You draw it back up into the syringe and give it to them in their thigh. The dextrose and water that we've talked about, that I mentioned, it's just basically an IV form. If you have IV access and you need to bring up their sugar very quickly, then this canister here fits into this syringe here, and then you basically attach it to the IV and just inject it straight into the IV. The other thing I spoke about, the oral treatments, Dex tabs, and what they're equivalent to is 4 grams of dextrose in a little tablet form, like a candy. You can also give orange juice. You can also give 6 fluid ounces of basically soda pop. Basically, make sure it's Coke regular and not Coke Zero, please. They can say sometimes skim milk, or you can give raisins. Anything that has anything that your parents said is bad for you because it's got too much sugar in it, they can have, and it will actually help to raise up their sugar. What we see a lot of diabetics using is a lot of them use dextrose tabs right now because they don't have to worry about that, what kind of sugar, whether or not it's a short chain glucose molecule, long chain, whatever. Dex tabs are the gold standard for oral hypoglycemics because it is dextrose and we know how quickly it should work. Within 10 to 15 minutes, we should see changes. And this is what the Dex tabs look like. They can get in a liquid form. They can get it in 10 tablets. They can get it in the King Kong Costco version, which is 50 tablets in here, and it even comes in a gel situation as well. There's some I will not expect you to know this for the test, but there are drug agents that will, you need to know that the ones that will promote hypoglycemia and hyperglycemia. Probably the most, I would say, out of all of these, the things that promote hypoglycemia, we see that there's NSAIDs, the sulfonamides here, because the next lecture that you're going to be doing on the type 2 medications, sulfonamides comes up. What's more important here is this one right here, ethanol, alcohol. Okay, as you're working with your patients, alcohol will drop their blood sugar, not make it go up, it will make it go down. Okay, ethanol, alcohol, these will make your blood sugar go down. All of these other ones over here, look at, this is very interesting, promoting hyperglycemia, steroids, estrogen. Gee, what are those? Those are hormones, counter-regulatory hormones. Okay, so it just goes to show you that and just be aware of these medications and know where to look them up and what will produce and non-produce. The main thing that you will need to know is, for especially your adult diabetic patients, alcohol drops their blood sugar. So what do you need to be doing? You need to be watching for hypoglycemia in those situations. And if you do have a patient with hypoglycemia, and what we basically, in these situations where somebody is passed out, it is, don't stick anything in their mouth, Okay, there's only one way to fix hypoglycemia. It's either glucagon or through an IV at that point in time. So no to use it for hypoglycemia. For a patient who is passed out, who is unable to drink or take anything in their mouth, you put anything in their mouth, you will kill them because they will choke. Okay, and not only do you have hypoglycemia, but then you're going to have, you're also going to have now, you're going to have an aspiration into their lungs. It is primarily glucagon, 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 or if you have an IV, D50.